And welcome back. I'm Mabel Zhang. Thanks for watching. You're looking at the World Healthcare Congress content here at the conference. And I'm in the studio with me now is Dr. Ruchika Fernandopulle, who is with Iora Health. Welcome back.
Thank you. It's good to be back.
Well, it's great to have a check-in with you because when we first spoke a few years ago, Iora was just getting off the ground. You had a lot of ambitions for it, and now it seems like some of those plans have really come together. Tell me what you've been up to.
So when we started Iora, our goal really was to build a new model of primary care from the ground up and do it at scale. I think there are a lot of people who've had little individual pilot practices that are interesting, but if we want to change healthcare, we have to do this at scale. And can we do that? So that's what we've done this year really, is get to scale. We went in the past 7 months from 12 practices, about 10,000 patients we're managing, about 120 team members, to triple in size. We have 45,000 patients today, 29 sites across 11 markets.
Right.
We have about 350 people who work for us,
Yes.
and we're going to double again by the end of the year.
Wow, and you've certainly gained a lot of attention from the VC community who's bringing in money too, and what do they see? What kind of promises are they seeing in your business?
So, I think this is for a very specific type of investor. So the proposition here is that we are going to transform healthcare. And I argue this is the biggest business problem in the country. The gap between, we spend $3.5 trillion with the T dollars on healthcare, and we know that probably a third, maybe more of that is waste. Again, be clear, waste is things that we're spending on, which is not just no value, but actually causes harm to people. So if we can actually reduce that waste and capture some of it, it's a huge opportunity.
Yes.
So I think what we need to do is find investors who are saying, let's actually maximize human impact, and then understand if we do that, we'll translate that into economics.
One of your pilot programs was in Nevada.
Yes.
And you worked with casino workers
Yes.
at the time. What did you learn from that to be able to spread it out to other locations?
Yeah, so that was our first practice we opened about 5 years ago. It's still open and still running. I think several things we learned. So one was, what the team needs to be. And I think we played with a variety of variants of it. Obviously we have doctors, but then you also have these folks we call health coaches who are from the community, speak the language of the people they serve. We have a nurse who plays a role we call a clinical team manager. We integrate a social worker into the team. We're now having a sort of a SWAT doctor, a doc who isn't seeing patients in the practice, but his job is to be able to flex out for the patients who are in the hospital, in a nursing home, go see them at home as well. So I think we just keep evolving the team is one thing.
Yes.
And I think we keep evolving our IT platform. So we made a decision early on that we couldn't use the existing electronic health records.
Okay.
They were sort of, despite all the hoo-ha and our tax money going to subsidize it, built for documenting, coding, and billing.
Okay.
They're transactional, and really what we needed was something that's more relational. So we built our own IT platform, and that continues to evolve.
Oh, fantastic. Now, your coaches, do you find that if you really want this to work for other organizations, is that really one of the keys, the follow-up? Not only having people come in for visits, but they need the follow-up care.
So I think a huge part of what we do, so in a typical system, when I used to work in my old practice, a patient would come to me and they had a diabetes and hypertension, and I'd say, look, I have 7 minutes. I'd say, look, you should exercise more, eat less, take your medicines, good luck, sucker, I'll see you in 3 months.
Right.
And then they come back in 3 months, I say, you bad patient, you were not compliant. They go, of course, if it was that easy, it wouldn't be a problem. And so what the health coaches really do is help the patients execute on the plan, right? So my job as a doctor, what I'm trained to do is diagnosis and treatment, help make the plan, but then is how do you actually execute on it? How are you going to eat better? How are you going to move more? How are you going to take your medicines? How do you understand what are you tracking? When are you going to call for help? All of those things, and that's what I think our coaches do. By the way, I don't love the word coach, health coach. My favorite word actually is something Paul Farmer uses in Partners in Health. He does it in Haiti, and he uses these community health workers.
Okay.
He calls them accompagnateurs. One who accompanies you in the journey to health.
Oh.
That's exactly captures the thing. Now, I can't spell accompagnateur, which is why we don't use
say it.
Right, which is why we don't use it and why we use health coach. But that gets a sense of what they do.
Okay.
And I think that's a big part of the model.
Okay, because people really do want the hand-holding, it sounds like.
It's interesting. A couple of our investors in our last round were Silicon Valley types. I think a lot of people in Silicon Valley somehow think that technology will solve healthcare.
Right.
right? And I think technology is going to play a huge role, but only linked to a human being, right? And what I call our health coaches or even our teams are effector arms. So yes, we need technology to figure out who are the people getting into trouble, what do we need to do, but a lot of companies which do data, big data, and they generate these beautiful reports that sit on people's desks.
Okay.
Right. Pretty reports that sit on people's desks don't change healthcare. What we can do is take the insight from that report, put it on a task list for that patient's health coach who has a relationship with them, who can then reach out and help that patient change something because of that. Right? So the human being effector arm linked to the data and technology, that's what will change healthcare.
So actionable information and really put into action
Yeah,
by someone.
By someone.
Yeah.
That's exactly right.
You've mentioned that you're going to double in size by the end of the year.
Yes.
Astounding. Where in the country will we see more Iora Health clinics?
So in general, we're actually this year decided, we spent a couple of years expanding tremendously. What we're doing this year, by and large, is going deeper. Is let's go and build multiple clinics and practices in the same geography for a variety of reasons. And what we're doing really is sort of, you've heard about ACOs.
Yes.
And a lot of ACOs are what I'd call top-down ACOs, start with a health system and somehow hope that it trickles down to actual patients.
Okay.
We flip that. What we're doing is building bottom-up ACOs, start with primary care, and then build on top of that some specialty care, relationships with hospitals, et cetera. But to do that well, we need to get to critical mass in a market.
Okay.
So almost all of our growth this year is going to be to go deeper in existing markets. So one new one we're going into is South Florida.
Ah, okay. What city there?
So Miami, Fort Lauderdale.
Okay.
So we're going to open 12 practices in South Florida.
Wow, wow.
So looking for lots of good people to come work with us. But I think it's a place where we think there's a real opportunity to improve how healthcare is being done. And
sounds like you're really doing it.
Yeah.
I mean, absolutely. Do you want to? Is there any other takeaway you want to leave with folks at this meeting?
You know, I think what we're doing, if you boil it down, you know, I call what we're doing high impact relationship-based care, and really I think it's that the current healthcare system has become so transactional. Document, code, bill. The fee-for-service payment model contributes to that. And I think if we want to fix healthcare, our insight is we need to get rid of the transactions and actually refocus on relationship. And that's what we do. Unfortunately, the system seems not to be getting that. So CMS just released a series of these advanced primary care programs. They all continue to be built on fee-for-service, right? So come on, like if we want to do innovative stuff, let's go all the way and try and allow people like us to say, let's just get rid of the fee-for-service and do something more creative, as opposed to building on the platform. My favorite quote to quote is, they asked Michelangelo, you know, how do you get the Pieta, this beautiful sculpture? And what he said is, I simply take a piece of rock and I chip away everything that's not the Pieta. Right? So the problem, I think, in healthcare is we keep adding stuff on. The way we're going to fix healthcare is add stuff on.
Right.
And maybe what we need to do is actually take stuff away.
And just keep it simple.
Right, and get back to the relationship, the thing that actually heals people, and then we'll actually make progress.
Makes sense to me. May I ask you, Dr. Fernandopulle, we love seeing you here. What keeps you coming back to this meeting?
So I think it's a great place to meet a lot of people who we know and like you, and lots of other people. And I think it's a good forum to get some ideas about what else is happening out there and how we can adapt to it.
All right. Thank you so much for your time today.
You're very welcome.
And I'm Mabel Zhang. Thanks for watching. Stay tuned.